Okay, good morning class. Today we are going to discuss a very important chapter, that is primary amenorrhea. Amenorrhea, as you know, is cessation of menstruation. It may be primary or secondary. Primary means when women have not observed menstruation, and secondary means if she has observed menstruation first, then for some pathological reason she stops her menstruation, that is the secondary amenorrhea. So the primary amenorrhea is absence of menses by the age of 13, when there is no visible development of secondary sexual characters, like there is no thelarchy, there is no pubarchy. And if the females that are 15 years of age, they didn't get the periods, even in presence of the secondary sexual characters, that is also known as primary amenorrhea. So if you see in this, there is involvement of the hypothalamic pituitary ovarian axis. The hypothalamus releases the gonadotrophin releasing hormones. Those gonadotrophin releasing hormones, they reach by the hypophyseal portal system to the pituitary gland in the interior part of the pituitary gland, and they act there, they cause a release of the gonadotrophins. The gonadotrophins are of two types. One is the FSH, follicle stimulating hormone, and second is the LH. These gonadotrophins, they act on the ovary and they cause a release of the hormones like estrogen and progesterone. In the first part of the cycle, as you know, there is a release of the FSH. FSH acts on the ovary and causes stimulation or development of the follicles. At the same time, there is production of the estrogen, which primes the uterus, and there is proliferation of the endometrium. Then after the ovulation, once ovulation is there, there is release of the LH. LH stimulates the production of the progesterone from the corpus luteum, and that causes the secretory phase, that is responsible for the secretory phase of the endometrium. And then if there is no conception, there of the endometrium, because the corpus luteum, it is not maintained, it becomes old, stops producing the estrogen and progesterone, and there is a release of the withdrawal, in fact, of the both progesterone, and the endometrium gets atrophies and it is shed, and women, they get bleeding. So we must know this in the cycle. The hypothalamus produces the gonadotrophin releasing hormone that acts on the pituitary. Pituitary produces the gonadotrophins, follicle stimulating hormone, and LH. And LH then they act on the endometrium, which is the inner lining of the uterus. So WHO describes three classes of the amenorrhea. Group 1 is when there is hypogonadotrophic hypogonadism. Group 2, eugonadotrophic, and group 3 is the hypergonadotrophic hypogonadism. Amenorrhea without secondary can be without the secondary sexual characters. Amenorrhea with secondary sexual characters and abnormalities of the pelvic anatomy may be associated with it, or it may be even amenorrhea with secondary sexual characters and the normal pelvic anatomy. So the amenorrhea without secondary sexual characters is usually hypogonadotrophic hypogonadism, which is associated with absence of the secondary sexual characters, like genetic disorders, number 1, which includes the Turner syndrome, in which there is one chromosome is absent, it is only 45X, or there are abnormal X chromosomes or mosaicism or pure gonadal dysgenesis, mixed gonadal dysgenesis. Second, these were the genetic abnormalities. Second is that when there are enzyme deficiencies like congenital adrenal hyperplasia, 17-alpha hydroxylase and 17-20 hydroxylase deficiency, aromatase deficiency, and galactosemia. Then third, which is the rare gonadotrophic receptor mutation, that is when there is mutation of the LH receptor and FSH receptor mutation. These receptors are actually the proteins. The hypogonadotrophic hypogonadism associated with the absence of secondary sexual characters. There may be either physiological delay or Kallmann syndrome. The genetic disorders like 5-alpha reductase deficiency or gonadotrophin releasing hormone mutation, follicle stimulating hormone deficiency, other hypothalamic pituitary dysfunction that lead to the primary amenorrhea may be either malnutrition, malabsorption, or anorexia nervosa, excessive exercise, vigorous exercise. Now, what is the Turner syndrome? Turner syndrome, there is only one X, 45X. This is the most common karyotypic abnormality causing gonadal failure and primary amenorrhea. Initially, they have normal ovarian development but ends up in accelerated atresia of the follicles causing fibrotic ovaries. They are recognized as streak ovaries. After the diagnosis of Turner is confirmed, studies should be performed to ensure the cardiac, renal, and autoimmune abnormalities because there is association of these disorders along with the Turner syndrome. The physical features in Turner syndrome, they usually have short stature, they have low hairline, characteristic facial features, or the fold of the skin under the neck, there is constriction of the aorta, poor breast development, shield-shaped thorax, widely spaced nipples, shortened metacarpals, small fingernails, elbow deformities, rudimentary or streak ovaries, there is no menstruation, and they have brown spots over the skin. The abnormal X chromosomes, those who are having 46 XX individuals with partial deletion of the X chromosomes, they have variable phenotypes depending upon the amount and the location of missing genetic material. Or there may be deletion of the long arm of the X chromosomes. They are having sexual infantilism, normal stature, no somatic abnormality, and streak gonads. Another abnormality is there may be deletion of the short arm of the chromosome. These patients, they are phenotypically similar to the individuals with the Turner syndrome, but they differ from the Turner syndrome in having intellectual disability and syndactyly. Now, what is the mosaicism? Patients who have primary amenorrhea is associated with the various mosaic states, the most common of which is 45X or 46XX. These have pure gonadal dysgenesis. The individuals, they are phenotypically females with sexual infantilism, but the primary amenorrhea, normal stature, and no karyotypic abnormality. They have pure gonadal dysgenesis. The gonads are usually streak. I think this is sufficient for today. Okay, thank you.